but maybe they don't have that ability to posteriorly tilt. They run with a big arch, they throw with a big arch, they kind of do a back handspring with a big arch, and it puts pressure on their back. Maybe they just need to learn how to control that motion. Every day, you essentially pay your dues by doing the harder thing when it's the right thing to do. Hey everyone, how you doing? Welcome back to Shift's YouTube channel. My name is Dave Tilley. Super excited to have you here. We are going to be talking about a very popular topic that's been requested. We're going to be talking about back pain, but particularly the type of back pain that comes when you bend backwards, which is extension. This is one that the medical providers really wanted to know more about. From my social media channels, I treat a lot of gymnasts and dancers and softball players and basketball players for back pain that involves bending backwards. With this in mind, there's a lot of things I think I often see as, maybe not getting looked at, or people are just staring at the back, which is very important, don't get me wrong. But unfortunately, sometimes that we just look at the back and we miss maybe there's another area that is not moving enough, that is not getting its adequate mobility or strength, and that is causing the back to back bend more. So we're gonna review this all in a nice little comprehensive video, a little bit more in depth today. But if this is your first time at the channel or your first time back in a while, do us a massive favor and please like and subscribe. Down below, click the notification bell to make sure you're getting alerts, because we are putting out a ton of great new content and videos that are requested from the audience. In the comment section, tell us what you want to learn about in the future to help these videos keep rolling out, because they're very popular, people really enjoy them, but we only want to make content that is helpful to you. So if there are topics you're dying to know about, medical, not medical, strength conditioning, gymnastics, not, anything related to that, we can happily make those videos for you. Without further ado, the 6 areas that you need to be thinking about when you back bend, and this is exactly what goes through my head when I interview somebody for evaluation, their subjective eval, or I'm doing something, is I'm thinking about, okay, what is happening locally at your back that is maybe irritable? Is there a soft tissue structure? Is there a joint structure? And there's a lot of talk out there between the biomechanics and pathomechanics world and the pain science world. I use them both. I've studied them all pretty in depth, and I think they're both overlapping, but I'm trying to figure out what is causing your lower back to hurt. Is there a specific structure? Do we need to make sure you don't have a stress fracture or a spondy fracture to rule out, or is it more just irritable and stuff like that? In that position, I'm looking at, okay, what's the back? There's a couple forces we'll talk about, right? And then I'm trying to look at, okay, what's happening above the lower back and what's happening below the lower back, things that I need to think about looking at and screening out, because chances are when someone's going to be modifying their activity for some time to let their back feel better, if there's a large mobility issue in one of these areas or a huge strength deficit in one of these areas, we're going to want to use that time when they're not super active in their sport or their daily life to try to clear up some of those problems that we'll talk about. How do we screen for these things? So first things first, we have to think about when someone does bend backwards, there's kind of 4 levels of an irritation you can have, okay, in terms of the actual back bending pain on what's called the facet joints. Okay, so you can have midline pain, right, which might be a spinous process impingement, where those 2 spinous processes actually bump into each other. It's called kissing spines. Okay, you can also have some irritation of the joints on the outside of the back, the facets, which close down together and cause some irritation. That can happen from a lot of back bending, like in gymnastics or ballet. That can happen from a lot of rotation and bending together, like swinging a baseball bat or throwing. That can also happen in hockey. That can happen in tennis. A lot of sports have this, right? But if it's more straight extension based and their pain is in the midline, that's probably going to be more the spinous process. If their pain is more extension and rotation together, that might be the pars inticularis, the facet kind of together. You can kind of have those 2 things as well. And then also sometimes might have just straight compression loading. Someone who jumps and lands, like for volleyball, for example, or basketball, if they land an extension with compression, that might be more of like an end plate issue. It could be the joint as well. It could be just like the facet joint gets irritated, causes some muscular spasm. The nerve might be irritated as well. But that is typically another kind of type of force you want to look for, right? So how do we screen for these different things? I like doing locally at the spine, depending on what I think is going on. The screens over here for more the pathology-based stuff. So here, right, I'm thinking about doing, for this direct extension, I'm going to be doing multi-segmental extension, which comes from the SFMA, but just standing and back bending. I'm also going to be doing a press-up test. Have someone lay on their stomach, push up with their hands as tall as they can, see if that causes pain in their lower back in the midline, because that might be those 2 spinous processes pushing together. For more the pars, the facet, right, we might do a pretty classic test, right? So a stork test, where they stand on one knee, bend, and kind of come back, and you give them some overpressure. We could also maybe do a version of this without gravity as involved, which is going on your elbows, hand behind your back, and turning that person up to look at the ceiling and giving them some overpressure and seeing if unilaterally you have some pain on one side, right? So that's going to be a prone on elbows test. And lastly, you can do a joint PA shearing test, right? So what you do in this test is you put one hand across their ASIS in the front, the other hand is on their opposite sided lumbar spine, and you're pushing forward on a vertebral body like a pars segment and pulling back on the ASIS, and you're kind of shearing that motion motion into extension, you're essentially poking and irritating the facet joint or what may be on the actual stress joint, as well as something might be irritated on the extension-based mechanism. A PA shearing test is another way to kind of do that unilateral extension or rotation. For the end plate, that compression, right, what we're doing in this situation is a heel drop test is typically good. So they push up on the balls of their toes and they drop down really hard, and you see if that force into the ground can cause some compression irritation that might aggravate their back, right? So it's a heel drop. Okay, another test I like to do to confirm this as well is going to be a seated compression test. So in this test, they sit on the edge of the table, kind of in a kitty corner on the angle there. They grab the table below them, they arch as much as they can, and they pull down into the table. And again, it mimics that compression in extension. So say if someone's having some jumping and landing pain, that might be something that could be used for as well. So a seated compression test is another way to kind of look at more the end plate possibly being irritated, or maybe it's extension and compression together. This might just be straight back bending, extension. This might be extension and rotation. This might be extension and compression together. So I use those tests to figure out what do I think what structures are involved, right? And also what's the sensitivity level of that person. If someone can't even move and they're very irritable, I work in direct practice access, so they come directly to me sometimes, and they can't do a press up, they can't move, they can't do it, and they're having back pain. I usually send them to a doctor for an x-ray and MRI just to make sure they don't have a spondy fracture or something like that. Okay, so this video, we're not going to dive into specifics of how do you treat spondies, just in the axis of here of what we're looking at. If someone's really not that irritable, they're kind of irritated, they're kind of not, they're doing okay, I might work with them for a couple weeks before we send them. So now that we have that, when we look above or below, I'm trying to think in my head, what is making maybe a couple of these segments, L5, S1, right, or the thoracolumbar junction of T12 to L1, what's making those segments move more in a hinge? Is there another area that's not being made up for, okay? So the first thing that I typically look for is going to be the shoulders, right? So I'm looking for overhead elevation, right? And the way that we're gonna do that is we're gonna lay them on their back. After they put their arms over the head, we see them maybe limited, lay them on their back, rotate their arms all the way up overhead and see if they have limited elevation. Okay, the big things that we're kind of looking for are going to be maybe a joint-based issue or maybe a soft tissue-based issue, right? So we've had other videos talking about overhead elevation that we'll link here, but essentially I'm gonna do some joint capsule testing, right, to see if they have any laxity problems there, some scarring, and I'm gonna look at some soft tissue, right? I'm gonna look at the lat, I'm gonna look at the teres major, I'm gonna look at the pec, all that kind of stuff is going together, maybe a little bit of a combination of both there. So I'm gonna screen out the joint versus the soft tissue and see why don't they have overhead elevation, quickly related to also the T-spine, right? The T-spine needs to extend and rotate. So we might do a thoracic spine clearing test where they curl up in a ball, hand behind the back, turn to the ceiling, and just isolate the T-spine and see how that goes. We might also do a seated rotation test on either side to see if maybe that is something that's showing up as an issue. So again, we would probably work on that together of a joint mobility, maybe some soft tissue stuff. Also keep in mind that both of these things can be strength or control issues. So maybe that person doesn't show their full motion when they're doing their skills, their back handsprings, that when they're throwing or running. It could just be that maybe they're mobile, but they don't have enough strength or control. You'd want to test that out as well with strength testing and watching live video of active motion versus passive motion. So maybe for T-spine, they have plenty of motion when they do it side to side and press up, but when they do an actual skill where they try to throw, they don't use that T-spine motion. That's going to be more of a control situation or some sort of strengthening or capacity issue you want to work on. So we'd look at the overhead elevation on the table. We'd look at the T-spine extension rotation as well. Okay, for the hips, we'd want to figure out why the hips maybe are extending or rotating, right? So we might want to do a Faber test to see if maybe they have some hip extension related problems where they can't abduct and externally rotate. Could be a hip joint problem itself if they have a cam or pinch or lesion or something like that. Could be an anterior pelvic tilt issue where they're so overarched that they can't hollow into their proper mechanics because they're stiff or they're not in really a strong core or active core. We've had some videos about that as well on core training we'll link, but maybe they don't have that ability to posteriorly tilt. They run with a big arch, they throw with the big arch, they kind of do a back handspring with a big arch and it puts pressure on their back. Maybe they just need to learn how to control that motion. Could also be an adductor soft tissue problem, right? It could be someone who's very stiff in the pectineus and the shoulder muscles of the adductors, pulling them into an overarch, and that's they're so stiff they can't hollow and get that space to really protect their back. We check a Faber, we also check a Thomas test, right? And then also the joint can also be an issue. So you would look at x-rays with that, right? You can also do a Craig's test to see if they're retroverted or anteverted, right? So soft tissue is gonna be Faber and Thomas. Look at the quad, look at the TFL, look at the hip flexors, the adductors, the joint in the x-ray along with a Craig's test. Craig's test, you lay them on their stomach, you palpate the middle of the greater trach and see where it kind of is looking down the middle. Normal, some are like 11 to 13, depending on the research that you read, but I think 8 sometimes is in there as a norm as well. But you're essentially seeing if there's super anteverted or retroverted, that's going to affect their ability to turn in, turn out, and extend. Okay, so we would use all these tests, and obviously based on what you find, if they can't extend their hips when they back bend, we want to work on the soft tissue. If it's an issue where they have a joint mobility issue or a structural issue, we want to teach them how to modify around that with different foot positions, or maybe when they're doing skills. But we're going to figure out, can they back bend from their hips equally as much as their back, right? We'd like to see all this motion being equally spread out across the bend. I always teach people ideally 25% from the shoulders, 25% from the T-spine, 25% from the lumbar spine, 25% from the hips. And I would go through this evaluation and I would look at these different things and see why maybe they don't have that. Okay, so that's usually the main part, is looking at the what's happening pain-wise here, which type of force is bothering them, what's going on with their thoracic spine and shoulders above, what's going on with their hips below. Okay, if everything is still cleared, I'm not really seeing something jumping out at me, the next thing I'm going to look at is the ankle. I want to see someone have enough ankle dorsiflexion, so if they squat, possibly for their sport, or they land, they're not going to be limited in their ankle and they're going to arch their back more. Okay, so we would use this, we would do a half kneeling dorsiflexion test. So we want to make sure that somebody has the ankle mobility to absorb the forces properly in a squat. If they're very, very stiff in their ankles, they might anterior pelvic tilt and drop more pressure on their lumbar spine when they land. Okay, the forces are extremely high in sports like gymnastics, volleyball, basketball with the landing forces. So you land like that, you're not really prepared for it. It can jar your back. It can give you a problem and an irritation of one of these structures. So I would look at a half kneeling dorsiflexion test, obviously work on what we find there, whether it's the calf, whether it's the ankle joint, maybe modify around some of their lifts to make it a box squat or elevate their heels temporarily while they do stuff. And lastly, specific to gymnastics, is if they still have an issue, I also want to look at the wrist. So I might do a quadruped rocking, right? Gymnastics is a weird sport where you do a lot of stuff on your hands. So you might need to get a full 110 degrees of extension of your wrist. If someone has very stiff wrists and they're going to go back to the beam, they don't have that motion, they don't want to crash on their head, or they don't want to tumble and land in their head. So they might not have the shoulder motion to work with. They'll arch their back more to make up for that limited wrist flexibility. Don't want to go super crazy in depth and bore people. We'll do a part 2 if people find this interesting, but this is how I screen people and look at the different things that might be causing extension-based back pain. Keep in mind, something we didn't talk about is that it could be that someone's very hypermobile, they have plenty of motion, they just need strength and they're just doing too much, right? It could very well be that they have a ton of motion and they're fine, but they're doing a ton of their sport. They're throwing a ton, they're hitting a ton, they're doing a whole bunch of new volleyball practices and jumping and landing, they're doing a whole bunch of back handsprings and gymnastics. They spike their training volume really fast in a short period of time. They maybe don't have the strength or the technique down, and that might be a big issue as well. So technique, programming, and proper control is going to be very, very important, especially in the younger ages. If we just do too much too fast, we're going to have a problem there. So really watching your program is crucial if you want to make sure you have these things long term. We'll keep it at there for now. If you guys enjoy this video, if there's something that's really useful for you, we can break these things down more. I can talk about how I treat these things. I can talk about what I would do in a 5-phase rehab program, really based on what you guys want to learn. So this one was asked for, so I wanted to do this one first. But if you enjoyed this, drop a comment below and let us know what you would like to learn more about related to extension-based back pain, flexion-based back pain. We can do a whole bunch of other stuff too for medical providers. But also just like and subscribe. Make sure you get the alarm for the notification bell, because a lot more things are going to come out in the next few weeks. We want to make sure you guys are the first to know. So hope you enjoyed this one, and I'll see you guys in the next video.